Good evening, everyone. Here Imran Abbas from Dubai. Again, we are live with another legend of bariatric surgery and expert of sleeve gastrectomy. As you know, so we have started this interview series with MGB OAGB, and we have finished this series of MGB OAGB, and there was great response from viewers, and we had a sum up session in June. That was a great achievement on this activity. And now we have started series of sleeve gastrectomy. That is one of the most common surgery, bariatric surgery at this globe. We have started sleeve gastrectomy series with Professor Patrick Noel, who is one of well-known bariatric surgeon and one of the expert of sleeve gastrectomy. And we will continue this series till December. And in December, we will have sum-up session. And luckily, today, we have another legend of bariatric surgery, Professor Muhammad Al-Hafi from Kuwait. He is well-known bariatric surgeon and also expert of bariatric surgery and also expert of sleeve gastrectomy. Today, this is great opportunity for all of us to know more about sleeve gastrectomy. Sir, so much thanks for your time. I know you are one of the most busy bariatric surgeon in Middle East. So much thanks for your acceptance, our invitation. Sir, over to you, sir, please.
First of all, thank you very much, Amran, for this invitation. It's a great honor to share with you in your program and your series of bariatric surgery. I think you are going to make history of this series for the seniors and the junior surgeons. They will learn a lot from this series. I myself personally learned a lot from the MGB series, and now I'm still learning from the sleeve gastrectomy series. And it's really great honor to be with you. And I will support all this series with you all the time.
Sir, this all achievement is with your support, with your help, and with your guidance.
Sure. Well, I am Dr. Muhammad Al-Hafi. I'm a graduate of the Royal College of Surgeons in Ireland and fellow of the Royal College of Surgeons in Edinburgh and fellow of the American College of Surgeons. I am a laparoscopic and bariatric trainer in J&J, and I'm SRCS accredited surgeon in bariatric and laparoscopic surgery and program director at Sidra Hospital in Kuwait. And I was a former Minister of Health in Kuwait.
Sir, great honor really to interview such a prestigious figure. Sir, because we, as you know better, we have some repeated questions. So because at the end, then we will have a sum-up session, and also we will prepare some clips of yours, and at that day, so same questions and answer we will show. Due to this, we will follow the same process and same questions, and during questions, we will take also some questions from our viewers on Facebook, because now we are live on Facebook group Global Laparoscopy.
Sure.
Sir, one of the questions, so about your journey of bariatric surgery, when you have started bariatric surgery?
Well, Amran, you know, I'm a laparoscopic surgeon, and I've been upper GI laparoscopic surgeon for some time. And in Kuwait, in 2003, the gastric banding started. But myself, I was a bit not sure to start this or not. So I saw the gastric band. I went to workshops, but I was not convinced at that time to start this procedure. I don't like to use any foreign body in the abdomen. You know, we are old enough to remember the angel check and the problems with the angel check and for the hiatus, the reflux. So I was a little bit hesitant to start the gastric band. So I said to myself, this surgery, I will not start it. So I just didn't think of bariatric until 2005. when the gastric bypass started to get popular in Kuwait. So I attended one of the conferences and workshop in gastric bypass. When I saw that surgery, I said, this is the future of bariatric surgery, and I'm going to start this surgery. You know, even before that, I was doing gastrectomies for cancer, and I did a lot of hiatus hernia repair and hilar myotomies, splenectomies, and I did a couple of cases of distal pancreatectomy. So I have a good experience in upper GI laparoscopy. So I have no problem doing to start doing this gastric bypass. So I went ahead and I did the gastric bypass in 2005. Not until 2007 when I started my sleeve gastrectomy. The way I started my sleeve gastrectomy is a bit, it's a patient dependent. You know, one day I was sitting in my office and I saw a patient. She was in her 20s and with her mother. So I explained to them, I was doing only the bypass, so I explained to them the bypass. So the mother said, doctor, I think this is very complicated surgery. I cannot do my daughter this surgery, and especially is going to get married, to have children. So I said, okay, I have another surgery, which I just heard about and I read about, and I know something about the surgery. So I explained to her the surgery, sleeve gastrectomy. When she saw me drawing the sleeve gastrectomy and how I just cut part of the stomach, she said, doctor, this I understood, but that one I couldn't understand. This is, I think, she said, this is a good surgery for my daughter, because you're not doing anything, you're just making the stomach smaller and she will eat little. So I said, okay, but I never did surgery before, and don't ask me what will happen later on. I read about it, I know everything about it, but still, this is your daughter will be the first one. She said, I trust you, and they came to you, and I don't mind doing the surgery. So I did the first surgery. It was in September 2007. Since then, I've been doing mostly sleeve gastrectomy, and you know, it's as everybody knows that it's sometimes it's patient's based, because when I explained the gastric bypass and the sleeve gastrectomy, most of the patients, they go for sleeve gastrectomy. Even the start of my career in sleeve gastrectomy, I was into bypass more. I was telling them bypass is non-surgery and is the gold standard for bariatric, but still the patients drove me to go to do sleeve gastrectomy more. And since then, I've been doing mostly sleeve gastrectomy. You know, when I started sleeve gastrectomy in Kuwait, my colleagues, they were asking me, this is a new surgery, and we don't know what will happen later on, and we're doing a bypass, and we know the bypass. So I said, okay, I think deep in my feeling that this surgery will be the future of the bariatric surgery, and I'm going to do the sleeve. You keep on going doing the bypass, and then we'll see. Now all my friends, they are doing the sleeve more than bypass.
Sir, excellent. So as you have mentioned, you have started sleeve gastrectomy since 2007. Now more than 1 decade, you are performing sleeve gastrectomy. What is my question now at this stage? Because already, as you have mentioned, you were bypass bariatric surgeon. You have started bypass in 2005, but okay, you, so due to people and also different things, so you have continue sleeve. What is my question? What percentage of total bariatric surgery practice is your sleeve gastrectomy? If you compare now, how many cases you perform? 60%, 70%, 50% are sleeve gastrectomy?
No, I'm doing now mainly sleeve gastrectomy, and 80% of my work is sleeve gastrectomy. 15% is the revisional surgery, and 5% other surgeries like bypass, mini gastric bypass, or chassis bypass. But mainly I'm doing sleeve gastrectomy. I'm convinced that sleeve gastrectomy should be the first choice for most of the patients. Maybe in a few patients, maybe you cannot choose sleeve, but for most of the patients, I think the first choice should be sleeve gastrectomy. Because it's simple, simple for the surgeon, simple for the patients, no intestinal rerouting, the axis, endoscopic axis is there, and the outcome, whether it's weight loss or metabolic effect, it's very good. And I think, and I'm convinced that the first choice for most of the patients should be sleeve gastrectomy. And then if there is 20 or 25%, they need another surgery. That's in the future.
Sir, I want to know about, because you have started now about 14 years sleeve gastrectomy, and I know, so your center is one of the busiest center in Middle East. How many surgeries you did till now, sleeve gastrectomy? Can you share?
Well, yeah, I have done till now 8,000 cases of sleeve gastrectomies, and the patients are very satisfied, and the outcome it's good, and things are going on.
Excellent, sir. So another question, because if you see, so if you're doing any type of surgery, you see the results, and definite with the passage of time, you change your technique, you change your steps. So if now, so about 1 decade, I am also doing this MGB, OAGB, and I have started bariatrics personally since 2005, but progressively I have changed different types of surgeries. And also we change that steps of surgery. So in sleeve gastrectomy, for better results, so which steps you have changed? Like, so this size of bougie, so starting from first stepler, from which part you start. So I want to know about these steps that you have changed during this period for better results.
Well, any surgeon, Imran, when he starts first surgery, the way he does it should get evolved and get changed, and you should do better for your patients because you read it more, you know it more, you know your way of doing the surgery is better than before. When I started, the bougie was 40 French, and I used to do just stapling without anything else. Just cut off the stomach and that's it. I didn't oversew or didn't put a clip or I didn't do anything. So it was just cutting of the stomach and come out. And then with time, I learned to do plication of the stable line. So I was plicating all my stable line. And then I started to put omotopexy with the plication. And lately, for the last around 8 months, I started doing like a pexy of the or cardiopexy of the upper part of the stomach. I just anchor the stomach to the left cross. So things are evolving and changing with time, and we are trying to do the best for our patients. And I'm doing all these steps for all my patients, and don't drop any step for any patient. So whatever patient I have, I do it the same way from A to Z. And now from January 2001 till now, we're doing the last thing is the anchoring of the upper part of the stomach to the left crust. Even the staples, I've changed a lot using stable, the color of staples. And in the start, I was using 2 greens and 3 blues. But now for my all my surgeries, I do all green, all the way the stomach. I think personally that the stomach needs no less than green cartilage. I use sometimes the black cartilage in males or redo surgeries. I use black and then green.
Sir, excellent, sir, excellellent. And so now I have one question. I like to know about this gastropexy. So what is your concern, the migration of sleeve in?
You know, we see a lot of migrations, especially I see some patients with the stomach in the chest. Some of them, they have symptoms, others they don't have symptoms. If they have symptoms, you have to go back and fix it. So I thought of it and I read about it. So I started doing this from January this year, and we will see what will happen. Till now, patients are happy and satisfied. We didn't have any, till now, no migrations, 8 months, and we hope not to have any migration, but still, this is the start and we will see. Imran, I'm anchoring the upper back of the stomach and stabilizing the stomach with the omentum and the prepancreatic fascia. So I try to fix the stomach all the way from up and down, trying not to have the stomach go to the chest, or helping our patients not to have reflux. Maybe this will help them in the future. The reflux will come down.
Sir, excellent. Sir, we are interested to see your video. If you have any video, please share.
Yeah, sure. Well, this is our port sides. Always I have 4 ports in the abdomen. This is 10mm port for the camera. This is 5 in the left upper quadrant of the patient, and this another 5 in the epigastrium, and 12mm ports in the right side, right upper quadrant of the patient. As we put the scope inside, we always put the first the bougie to evacuate the stomach from any air or fluids. And when we pull the stomach, we just look at the hiatus. If there is a big hiatus hernia or any size of hiatus hernia, if any size of hiatus hernia, we always fix it. And I always count 3 centimeters. This is another change, Imran. When we started, I used to do it 6 to 8 centimeters from the pylorus. Now we do it only 3 centimeters. And I always like to put a mark, so when I go down, I know where my place is. So we start in the middle of the stomach and dissect the omentum of the greater curvature, and we stick to the greater curvature. We don't like to leave behind any greater omentum or any part of it, any fat.
Sir, excellent.
So now we'll go down, and we go all the way down to the pylorus. I always like to go down first before going up, all the way up.
Sir, one question: why now you have started 3 centimeters from pylorus?
Imran, I think leaving the big antrum, this is a cause of weight regain in the future, because the antrum gets bigger and the patient will eat more, and they will have a weight regain. So with the smaller antrum, I think the weight regain, and this is proven by studies, that the weight regain will be much less.
Okay, sir.
And I like to go down to free the stomach. So when I move the stomach will be mobile, and I can see the left cross much better than when you leave this to the stomach. I'm going to have another thing. You see that grasper, the left upper quadrant, left gastric port, we have a grasper. We use a grasper. So that grasper will do 2 things. We retract the liver and we retract the stomach.
Excellent. Yeah, sir. This is great.
And instead of putting like a liver retractor without nothing, this will help you. Both things, retraction, and can see the way. Look, retract the stomach and retract the liver. Yeah. And you can see the whole posterior aspect of the stomach, and you can free all the attachment, posterior attachment. And this is here in the short gastric is very important that the doctor should take care of the short gastric, because here's the bleeding points. If you are not careful, you might have bleeding, and you should control that bleeding in all aspects that you can. But if you do it carefully, you can see there's no bleeding. And see, look at the cross, and we know there is no hiatus hernia. The cross is very good, and we just dissect all the cross down. And any posterior attachment, we just take it away. After that, we just pass the 36 French bougie. The bougie is already there, And this is our first stapler. As you see, it's black. This patient had the balloon before the sleeve. She had a history of balloon. Any patient with history of balloon or any redo, I always put the black one first. And sometimes you always get bleeding in the edge. If you have bleeding there, we will just fix it with the clip. And then we continue with our staplers and use all the way. I see this is the line of our transection. So I know that my transection will go all the way down this way. And you say, I always look at the vessels and put them at the edge of the vessels. I don't go just tuck to the bougie. I just put them at the edge of these vessels. Not too much of traction. And you see the way I do it from below, I take the whole fundus away from me. So this will reduce your usage of stapler. You know, most of my cases, I do it in 4 cartridges. You see the fundus all the way, take it away from you. And this is the last stapler. You just keep away at least 1 to 1.5 centimeters from the esophagus. And this is the way I do my anchoring technique. You see, with the lift cross and plicate the whole stable line. Imran, when I started my plication, you know, people that talk about timing. When I started this, yes, it took me at least half an hour to do this. Now I do this plication in 7 minutes.
Yeah,
and the whole surgery takes me from 25 to 30 minutes.
Excellent.
So this is the way I do it. Look, we take the lift cross and plicate the whole stomach.
Because our target of this interview is safe sleeve gastrectomy, and we have viewers, youngsters. So in my opinion, this is the great opportunity for them to know. Now you can see Professor how is doing, fixing, and also every step is very important. Excellent, sir.
Imran, I think the title of your series, it's very intelligent that you put a save sleeve gastrectomy.
Thank you,
and
sir.
This is very true that surgeon should be as safe as he can to give his patients the best outcome.
Yeah.
So whatever you think that will help your patient, you should do it. And that's now the momentum. We take it all the way to cover our plication and to stabilize the stomach. But when you just hold it, when you just pull it away, you know that the stomach is turning back to normal.
Yeah.
But if you leave it without this, then the stomach is rotating.
So when you will do this omentopexy, then there is less chance of twisting of this sleeve.
I'm taking that well, sorry, I'm taking the prepicratic fascia as well and fixing it to the stomach as well.
Excellent.
So all the things that I think I can help my patients, I try to do it. And thank God we have good results with our patients. Even the weight regain with this type of surgeries, we think it's much less than other type of surgeries. I go all the way down. I look at the vessels and try to avoid them.
Excellent, sir. And also, as you have mentioned, also in some stitches you have taken that pancreatic fascia that will fix stomach in this position, natural position.
Absolutely. You know, if you just take the omentum with you, this is another point of bleeding. So if you take the omentum with you and fix it this way, at least you know that the bleeding from the omental side is much less. So you're covering the bleeding points of the stable line and the bleeding points of the omentum.
Agree, sir. Agree with you.
And when you cover the stable line, the whole stable line, the stable line is a raw area. So, you know, when we go back to in our patient to do laparoscopic hysterectomy or something else, there will be no adhesions at all, as if it's a virgin abdomen. And then you wash and take the stomach out from the 12 millimeter.
Sir, excellent, really excellent and very impressive, very impressive. So just my question regarding this omentopexy and this gastropexy after this technique. Now you are happy, especially GERD after a sleeve gastrectomy?
Well, we see, but the percentage is very low. Lately, the patients are taking, we start always our patients with PPI for 3 months post surgery. Most of them now, they're quitting the PPI after 3 months. In the past, most of them, they're taking PPI for a long time. So I think with time, maybe we'll publish this, that our patients are taking much less PPI or they're stopping the PPI much earlier than others.
Sir, excellent. Sir, I have another question regarding pre-op endoscopy and H. pylori eradication before surgery. What is your practice?
As you said, we are now changing. So when I started my bariatric surgeries, I used to do all my patients with endoscopies and eradicate the H. pylori. And then when the sleeve gastrectomy came along, in the start, I was doing all my patients. But then I was thinking, why should I do all the patients? I did many patients, I had no problem and no change in my strategies or they changed the time of surgery. So I started doing selectively for patients above 50 or patients with symptomatic. And we're doing okay, but now I'm doing routine endoscopies because it's the guidelines advised to do routine endoscopy for all the patients. I always follow the guidelines. I follow what the best procedures for the patients. So now we are doing all our patients endoscopies. If the patient is symptomatic or above 50, we do the endoscopy before surgery. If the patient is young and not symptomatic, we do it the same sitting. We do the endoscopy and the sleeve gastrectomy in the same sitting.
Sir, what do you mean symptomatic? If patient is suffering with GERD and GERD symptoms, what is the criteria? So my question regarding, so which patient, so you will not prefer to do a sleeve gastrectomy. So in your criteria, what is the relative and absolute contraindication of a sleeve?
Well, I think nothing, no absolute contraindication for sleeve gastrectomy except diagnosed Bariatric esophagus. If you really diagnose the Bariatric esophagus, this is a real contraindication. But if the patient having reflux symptoms, if the reflux esophagitis grade A or B, we go ahead and do the sleeve gastrectomy. But if it's a grade C, we tell the patient, this is the situation. You have a grade C esophagitis. If we do your gastrectomy, you might get worse. You have a chance of getting better. You have a chance of getting the same, or you have a chance to be worse. Most of the patients here, Imran, they prefer sleeve gastrectomy. One of the patients said, what will happen? I said, will you continue your PPI? I said, doctor, I'm taking PPI anyway. So I don't mind taking the PPI even after surgery. So most of them, they go ahead with the sleeve gastrectomies. Small percentage of patients, very, very small percentage of patients, they might need gastric bypass for reflux or worse reflux symptoms after surgery. But this is very, very rare, 1 or 2% of our patients will do that.
Okay, sir. So it means, sir, this is a good result. So if we see now you did about 8,000 sleeve gastrectomy, and also you prefer sleeve gastrectomy in the patient with GERD symptoms, and after surgery, so definite patient is happy. So now this is the small percentage symptoms have been worst, and you have changed to Roux-en-Y, I think, as you have mentioned.
Imran, I can tell you one story of one of the patients. When I started the sleeve gastrectomy, I was doing sleeve gastrectomy, only surgeon doing sleeve gastrectomy. I have one patient, she went to many doctors and they advised her for a bypass. She came to me, she has hiatus hernia and obesity. So I told her, yes, what my colleagues told you, they are absolutely right. The best solution for you is the bypass. But she said, doctor, I don't want this surgery. I'm afraid to go into troubles with this surgery. They don't want to go. The problem that time that the patient thinks that sleeve, they will not take supplements all their life, but the bypass, they will take supplement all their life. She said, I don't want to take supplement all my life. So I said, okay, I'll fix your hernia and I'll do your sleeve and we'll see the result. Some result, the literature said that some patients, they get better because you lose weight. When you lose weight, the reflux symptoms might get better. And I went ahead and I did that surgery. That patient till now, she's really happy. She sent me all her friends or her family to do a sleeve gastrectomy.
Excellent. Sir, what is your opinion about hiatal hernia? If you diagnosed hiatal hernia before surgery, so have you any criteria for, yeah or no, you repair all types of hiatal hernia and you will go ahead for a sleeve gastrectomy? What is your experience?
Yeah, there is diagnosed hiatus hernia. I give the patient the options, bypass or sleeve gastrectomy. But I tell you, most of our patients here, they believe in sleeve more than us. So they prefer it because simple, they know, they see their other patients because it's very common now, sleeve gastrectomy in the whole world, not only in Kuwait. So they go ahead and they ask me to do a sleeve gastrectomy and I go ahead to do it. Excellent. I don't mind that patient with hiatus hernia and sleeve. I repair this hiatus and I do all the fixes I can and give them the best chance.
Sir, excellent, excellent. Sir, as you have mentioned earlier, so now your main practice is a sleeve gastrectomy and you did about 8,000 case of sleeve gastrectomy. Definite, you have faced leak after a sleeve gastrectomy. So which steps you have changed for prevention of, we cannot stop, I know 100%, but we can prevent leak after a sleeve gastrectomy. So what is your tips and tricks to decrease the percentage of leak?
Well, Imran, complications are fact of life in surgery and in surgical life. So we have to face them and everybody will face these complications. The steps I change for prevent or try to reduce the rate of leak rate is the plication and the omentum. I think these two steps, they reduce the leak much more than what I used to practice. And the start, I had some leaks. I'm still having leaks, but much less than before. You know, my third case of sleeve gastrectomy, I had a leak. But the leak, Imran, was from the antrum, not from the angle first. So we went back second day and just fixed it like perforated DU. I stitched it and put an omentum there, a omental patch. From that time, I was thinking, should I do all this for all my patients? And in 2010, I started doing this for all my patients.
Sir, excellent, excellent. Because now, as we see this video, so definite, it was amazing. And sir, I have one question regarding your stepper, because you have mentioned, so you prefer all green or black, because we have different types of patients. So we have female patients, we have male patients. The thickness of stomach is much different. So if any patient, so thickness in antrum region is more thickness as compared to so angle of his. So when we use this stapler, that with height, more height, there is more chance of bleeding at that area, as you know better. But again, because you plicate that one and also omentopexy, maybe due to this, there is less chance of bleeding.
Yeah, that's why, Imran. I think I'm afraid of leak more than bleeding. So getting a higher stable is much better than getting a smaller one. And then practiced this in 2013. All my cases, all the stomach, from the antrum till the fundus, all green. I use black only in males, big males with a big BMI, or irido cases. Otherwise, all green. As you said, the bleeding points, I know that I'm doing plicating the whole stable line and putting the momentum, so I'm not afraid of bleeding.
Sir, have you faced any portal vein thrombosis or any thrombosis after sleeve gastrectomy?
Well, Imran, people think that the reflux is the Achilles heel of the sleeve. I think, personally, I think that portal vein thrombosis is the Achilles heel of the sleeve gastrectomy, because we don't know still now why the portal vein thrombosis is peculiar to sleeve gastrectomies. We do a lot of other surgeries, but we faced some cases of portal vein thrombosis post sleep, and sometimes these cases are fatal if they don't have high suspicion and diagnose them early and give them the anticoagulant. You might lose your patient. So my advice for all bariatric surgeons or sleeve surgeons especially, to take care of this complication. You will face it. All of us will face it. But your juniors should know that this complication is there, and any patient with abnormal abdominal pain, especially in the first 2 weeks, go ahead and do a CT scan. You have to diagnose, rule out the portal vein thrombosis. Otherwise, if you miss the patient, he will present in a bad situation and you will not save him. Or if you save him, you will save him with a bowel resection. So you don't want to reach that stage. All my junior staff with me, then they have this protocol. If the patient comes anytime after surgery with abnormal pain or something that click the point that he has something in the abdomen, we go ahead for a CT, contrast CT.
Sir, how can we prevent?
Should take care of this entity. Maybe it's underreported. I think it's underreported, the portal vein thrombosis. But it's there until we know the cause and try to prevent it. Otherwise, you will see some patients with the portal vein thrombosis. And the portal vein thrombosis not only might lose their bowel. Sometimes they might even go with portal vein thrombosis to liver failure and liver transplant. We don't want to get to our patient to that stage.
Sir, my question, so how can we prevent this portal vein thrombosis? Some of bariatric surgeons, what's their opinion? So one of the reason after a sleeve gastrectomy is dehydration, because this is a restricted procedure and patient cannot drink about 1.5 till 2 liters. Maybe this is one of the cause of portal vein thrombosis. So they prefer continue intravenous fluid after surgery. Patient cannot drink. They discharge the patient next day, but so they prefer to continue to 3 days this IV therapy, intravenous serum therapy. Are you agree?
This part of this one theory of the portal vein thrombosis is dehydration. But most of the patients post-sleep, they are dehydrated. But only certain patients or a few patients, they get that. Whether the dehydration is the reason maybe. But in our patients, our setting, we always give the patients like a prescription. If you think you are not drinking enough fluid, come to the hospital and get this prescription of IV fluids. And most of them, or some of them, they come back to get this IV fluids if they think they are not drinking enough. But if they are drinking enough and they are okay, I don't think they need to come. They don't need to come for regular IV fluids. Imran, something peculiar about this stabilization of the stomach with the momentum. The patient, they come to me after 1 week after surgery, they tell me, doctor, are you sure you cut my stomach? Because I'm thinking, okay, I have no problem drinking. I have no nausea, no vomiting. Are you sure you did sleep gastrectomy for me? I said, yes, I'm sure. But this is the way the surgery is. You're drinking nicely, you should be happy. They say see other patients, they're vomiting. They tell me, why I don't vomit? I want to vomit like others. No, you're better than them. So maybe this is another trick of doing the sleeve with the multiplexing. The lifestyle after is much better than without.
Sir, excellent. So yes, I agree with you. So same surgery, same standard, but different results in different people. So what is my question now? You're following your patients more than 1 decade, especially after sleeve gastrectomy. Which percentage of your patients gain weight?
Well, I have around 25 to 30% of patients they gain weight, but not all of these 30% they need surgery. You know, regain weight is not an emergency. If the patient come to you with regain weight, there is no problem. It's not an emergency. You should try to counsel them with the lifestyle, exercise. Sometimes if they need to do, they have a Saxenda, something non-invasive. With all these steps, if they are failing again, then we think of surgery. But I don't go rush for surgery whether the patient having reflux or weight regain. I try to change their lifestyle with their food habit and other measures. If they succeed, it's much better for them. If not, we'll go for another surgery.
Sir, if you so because now my question is about which percentage of your patient have you revised due to weight regain? So can you share your experience?
Yeah, I revised around 20% of my patients. I have revised them, and most of them they come back to me and they said, I want a resleeve. Even after, yeah, you know, the first case I did in September, her BMI was 50 and she came down to a BMI of 24. 11 years later, she came to me with a BMI of 38. And her mother, they came to me again. And she told me, doctor, I want the same surgery. I told her, I cannot promise to do this surgery for you again, unless I do this CT volumetry and do endoscopy. If you are a candidate for resleeve, I will do a resleeve. If not, I will not do a resleeve. So she was a candidate because the first case, the stomach was a little bit big anyway. Yeah. So we went back and I did the resleeve and she's happy. And you know, during this 11 years, she got married and she had 2 children.
MashaAllah. So again, so sir, this is also another question because you have mentioned still you prefer re-sleeve or no? You will go, what is your preference?
Myself, before I discuss anything with the patient, I tell them, I cannot tell you what to do for you. I have to do the CT volumetry to see the stomach size, and then if there is a hiatus hernia, big hiatus hernia or not, and if there was a twist or not, and they do endoscopy to see if there is a esophagitis, what degree of esophagitis, the size of the stomach as well, or if any kink or twist. I gather all this information and I sit with my patient and tell them, I can do resleeve, I can do a bypass, I can do mini bypass, and they give them the percentage of weight loss and the failure rate of, because I tell them the first surgery is the best surgery. The second surgery, the weight loss is much less than the first surgery. But the thing is, most of the patients, they choose resleeve. And the good thing that they are choosing a resleeve and they lose weight. And some of the patients, they go for a bypass, they don't lose weight. maybe the reflux is better, but the weight loss is much less than a sleeve, at least in my practice. And the mini bypass, yes, they are 80% of the patients are losing, they have a good weight loss, but still 20% they don't have a good weight loss.
Sir, excellent. Really, because, and also as you have mentioned, so because GERD after sleeve gastrectomy also is another challenge. So which percentage of your patient are suffering with GERD after the sleeve gastrectomy?
Yeah, I think same range is around 30% to 35% of the patients they have in GERD, and they're using a PPI. I'm doing now a lot of redo surgeries, and most of the patients of our redo, because we are doing mostly sleeve, or so most of the redos are post sleeve, and we are doing endoscopy for them, and around 20 to 25% they have esophagitis. The rest are okay, they're not using even a PPI. So I think the reflux, they're talking about the reflux, they're saying it's Achilles heel of the sleeve gastrectomy. It's not that much, at least in our part of the world. We don't have that problem of Barrett. I never seen a Barrett esophagus either before sleep or after sleep. And the esophagitis, most of them, if they have esophagitis, is grade A. So there's not really a concern of what the patient I'm seeing.
Yeah, I agree, sir. I agree. So regarding this GERD, because you know better, so really this is a main issue nowadays, and discussion on different platforms internationally. So which percentage of your cases you have revised due to GERD?
Not much. I revised it to bypass less than 5%.
Less than 5%.
Most of them, they don't mind going on with the PPI, and a lot of them, when they check their lifestyle, I ask them to check the way they are eating and the type of food they're eating. And if they are a smoker, we ask them to stop smoking. And when they do this, most of them, they get better, or they use their PPI like on demand, not all the time. The patient with the reflux and smoking, I can't offer him bypass. If I offer him a bypass, I'll put him from change from the reflux to a marginal ulcer. So that's why sometimes you get to be, you have to study your patient in the whole, not just because he has the reflux, you go for a bypass. If the patient with the reflux and heavy smoker, if you go for a bypass or a mini gastric bypass, so the rate of marginal ulcer will be much more than the problem of reflux itself.
Yeah, sir, one of the issue, because we know, as you know better than me, sleeve gastrectomy is a restrictive procedure. And one of the issue after sleeve gastrectomy, long time, is pseudoachalasia. Have you faced such a situation in your patients?
Till now, no. Well, pseudoachalasia, we see it after like a band. After a band, we see the dilatation of the esophagus, but in the sleeve, I haven't seen it.
You never faced such a situation. Yeah. So after the, sir, when patient is suffering with GERD, so as you have mentioned, about 25 to 30% of patients, they complain GERD after surgery. How you follow your patients? Is it routine to do post-op endoscopy, or no, only selected patient you prefer to do endoscopy?
I do in selective cases, and if the patient is going with the weight regain going for surgery, I do. Otherwise, I don't do it like a routine or surveillance. Till now, I don't think that we need to do it for all the patients, unless the patient is really symptomatic, or if you are doing a study that you should do endoscopy and follow your patient. But otherwise, I'm telling you, I'm seeing a lot of, at least 15% of my cases now revision, and we do a lot of endoscopies for them, and we haven't faced that problem. So I don't think it's really mandatory to do surveillance for all patients after sleep.
Yeah. So this is great experience, because now till this time you did more than 8,000 sleeve gastrectomy. So during this period, any of your patient is suffering with Barrett esophagus after sleeve gastrectomy?
I haven't seen any Barrett esophagus, I tell you. I haven't seen it before or after. I think in our part of the world, Barrett is very rare, and we are fortunate that Barrett is very rare, and gastric cancer is very rare. So maybe we are lucky.
So as you mentioned, sir, so the sleeve gastrectomy is a good surgery. So if you follow that standard steps, and because sleeve is not simple surgery, because this message is for our youngsters. Sleeve is not simple surgery.
Sleeve is simple, but not easy.
Yeah.
If you look at the sleeve, it's very simple, but not easy to do. And you have to learn, you take steps, and you will learn by time. So simple, it's simple, but it's not easy to do.
I agree. Sir, what is your opinion about endoscopic gastroplasty? Have you any experience?
Well, unfortunately, I don't have any experience, so I cannot say anything about it because I'm not practicing it. But I tell you that I see a lot of patients coming after the gastroplasty, and I revise them to a sleeve gastrectomy. Unfortunately, when we do the endoscopy for them, we see most of the stitches are cut through. They're not taking they're not staying in place. So most of the stitches are cut through, and we go ahead and do sleeve gastrectomy for them. My advice for all the people doing gastroplasty, endoscopic gastroplasty, is to choose the right patient. If you don't choose the right patient, the results will be very bad. So if you have bad results, you'll have bad reputation. So patients with gastroplasty, you cannot do like a BMI 45 or 50 a gastroplasty. They will not lose weight. And we know that patients with gastroplasty, they lose 10, 20% of their excess weight loss. So you should choose the right patient and choose the right BMI. If they understand what they're doing, you go ahead and do it. Otherwise, don't do it just for the sake of doing the procedure. Likewise, the balloon. Now we have a lot of people, I'm one of them, we're doing a lot of balloons. But if you don't choose the right patient for the balloon, it will give you a bad reputation. I can tell you from here that doctors doing balloons and gastroplasty and gastric band, you will have bad reputation because the results are not good. But the sleeve gastrectomy, they give you a good reputation because most of the patients, they lose their weight. The main objective for the patients for doing these kind of surgeries is to lose weight. If they don't lose weight, they start saying, why they did the surgery for me, doctor? Why I'm not losing weight? So choosing the right patients, the criteria, they should have standard criteria for patients for gastroplasty. Otherwise, everybody will do any patient, and the results will be like the pose, when they started the pose before even the gastroplasty, they were doing any patients. So the results were not that great. And that's why patient, and even surgeons, they shifted for only surgery, not doing these kind of surgery. So I'm not doing it.
Yeah, excellent. Sir, as you know better, so obesity is a chronic disease. Obesity is a disease, is a chronic disease. There is no doubt. And if we do bariatric surgery, any type, no, not only restrictive, any type, so there is chance of complication, there is chance of weight regain. Till in gastric bypass, we can face chance of, what is my question? So when you are doing a restrictive procedure, especially sleeve gastrectomy, there is more chance of weight regain. Can you ask our patients? So yes, because now just think, patient is 25 years, young patient, morbid obese, and we are going to do sleeve gastrectomy. And if we expect life expectancy 80, 90, so something like this, so in Middle East. So now patient will weight regain or gain, and so maybe we will do again and again 2 or 3 times bariatric surgery for this patient. Can we take such a consent from patient or no need?
Well, in super obese patients, I always tell them if they choose sleep for them, or if they come for a sleep, I always tell them this is maybe a first stage procedure. You might need another stage procedure. But still, in doing a sleeve, you know, when you do a sleeve and patient come to you with a weight regain, you have a variety of procedures to do. But if the patient comes after a bypass, I think we are stuck. Till this moment, after weight regain, after a bypass, we don't know still what to do. Like I can ask you this question, Amran, if you are sitting in your office and your secretary tell you, I have a patient with a weight regain post bariatric surgery. Which one would you like that patient which surgery would like that patient he had? If the patient comes to you and tell you this, I have bypass, you will feel a little bit bad, or what shall I do to you? But if the patient comes to you and say, I have a sleeve, you are relieved, you will say, yes, I can do a lot of things to you. So
I agree.
Keeping this in mind, that's why I said the first choice, or my first choice, or my first priority, or my first attention for all my patients with obesity is sleep. I always can do something about them later on. We know that bypass and sleeve gastrectomy, after 7-10 years, we have 25 to 30% of them with the weight regain. But the 25-30% of the sleeve, you can do something. The 25-30% of the bypass, it's difficult to do it. So
agree, sir. I agree. Sir, as you mentioned, so you prefer PPI about 3 months after sleeve gastrectomy. Or you prefer supplements after sleeve gastrectomy? Have you faced any micronutrient deficiencies?
Yeah, we faced some of the nutritional deficiencies, rare, but they are still there. And patients who are not taking the supplement, and they're not eating the way we're asking to do. You know, we ask our patients to take 4 to 5 small meals a day with high protein diet, but some patients they take only one diet a day, or small portions. They're not eating very well. Once you put them in the right way and they give them the supplement, most of them they reverse back to normal. So I always start them in supplement, and I do routinely every 3 months the blood test, full blood test, and the vitamin test. And if I find anything, I just correct them. If they need something else, I just add to them. And for the first year, it's mandatory for all my patients to come back and to do blood test every 3 months. I see my patient 1 week after surgery, and then I see them 1 month after surgery, then I see them every 3 months, first year. And then I see them every 6 months, second year, and once a year after. So all my patients are put on the supplements. But, you know, it's Amran, some patients, you know, they don't like to come back to you, and they don't show up, and you see them after. You see them in an occasion or somewhere, not in a clinic or not in a hospital, anywhere else. You know, Kuwait is a very small country, and we see our patient, and they can recognize us, and they can say hello to us. And if I ask them, why don't you come back? Say, doctor, I'm okay. Did you take your supplement? He said, I take them for a few months, and that's it. I'm okay now. And they see, and I know patients that are relative of mine, and they see them regular basis. And after a few months, they stop their supplements, and they're okay. But in bypass or mini bypass, the follow-up should be very strict, and the patient should follow up strictly. In sleep, we like them to come back, but most of them, they're okay, and they don't come back.
Sir, nowadays, one of the hot topic is metabolic surgery, a patient suffering with diabetes. And just imagine, and a patient is 40, 45 years old, not old patient, are you also prefer sleeve gastrectomy, and have you achieved good results?
Yes, because Imran, most of the patients with diabetes, they come to us, they say, my neighbor, he had the sleeve and now he's not using any tablet, not using insulin. So they come specifically asking for the sleeve. The results of diabetes resolution after sleep is good, and we know it's good. It's compared to maybe bypass much or just a little bit better than sleep. But in the long run, they are the same. But imagine if this patient with a sleeve had recurrence of the diabetes. As I said, you can do a lot of variety of surgeries. But imagine if the patient with bypass has remission or diabetes again. What shall we do to them? It's always difficult with the bypass to resolve their problem. I mean, afterwards. But in the sleeve, you can always do a lot of surgeries, the intestinal part surgeries. So we reserve this intestinal part surgeries for the second surgery, which is around 20 to 25% of the patients. So you have at least 75 to 80% of your patients, they don't need any other surgeries.
Sir, excellent. Really, it was a great, in my opinion, informative interview, because you have shared your personal experience, and this is the target of our interview. Because if you see any seminar, any webinar, especially, there are 10 experts are sitting and they have no time, just 5 minutes, 10 minutes. And always this thirst remains from viewers, from all these youngsters. So now due to this, we have started this interview, and it was a great opportunity. And also this interview will remain on this Facebook group, and our viewers will watch this interview, and also that video that was exact. So tips and tricks of safe sleeve gastrectomy, that was very effective. Sir, really appreciable for your time. Sir, any message for youngsters who are going to start sleeve gastrectomy?
Yes, for the young surgeons, as we said that the sleeve is simple but not easy. Try to learn it from your expert surgeons. They are lucky. The young are much luckier than us. And our time, we couldn't see all this type of videos and all this type of interviews. So we have to look for all this. But now they have this available for them. They should see the surgery. I always advise my young surgeons to be active in theater. Not only to see the video from the screen, you have to see the surgeon, how he moves his hand. This is very important. And the sleeve gastrectomy is a good surgery to learn intracorporeal stitches. If you do oversewing or plication of the stable line, this is a good opportunity for you to learn it, because we don't want you to do intracorporeal stitches in anastomosis. It will be very difficult. So once you know how handling the needles and doing the stitches with the sleeve gastrectomy, this will help you in the future for any problems with your intracorporeal stitches. A lot of surgeons till now, they cannot do intracorporeal stitches because they're afraid to do it. But if they learn this or learn themselves with the sleeve gastrectomy, this is a good opportunity for them. I always tell my juniors, don't forget your mentors. Always think of your mentors and thank your mentors. That's why I'm taking this opportunity to thank my own mentors. They teach me the surgery, laparoscopic surgery, and all when they were taking care of me. I have 5 mentors. If you may allow me to say their names, to thank them: Dr. Hilal Al-Sayer, Dr. Talib Jum'a, Dr. Sabah Al-Hadidi, Dr. Abdurrahman Khafaji, and Dr. Tarif Al-Adi. These 5, they affected my life in surgery, and they taught me until I become a real consultant surgeon. And I thank them a lot for what they did for me. And I take this opportunity as well to thank Sidra Hospital in Kuwait. the administration and the medical part, the surgeon, anesthetists, nurses, for taking care and supporting me with the high volume of surgeries we are doing and taking care of my patients. I thank them all for their support and their time. They are really having most of their time in the hospital just to help our patients and to be there when they are needed. And last but not least, I thank you very much, Imran, for this interview. And I hope I wish you all the best in this series. And I'm telling you, you are making history for the bariatric surgeons.
Sir, your greatness, definite. When you acknowledge your mentors and also your team, you are a great person. And as you have mentioned, so MDT, multidisciplinary team, is the base of bariatric surgery. And this is the great message from Professor Muhammad Al-Hafi for our youngsters. Please, if you are going to do surgery, first of all, complete your learning curve under a mentor, then under supervision of a mentor, then MDT, that is a multidisciplinary team, that is the base. That is very important. Then you will achieve better and best results. Sir, so much thanks for your time. I know you are so much busy and it is great honor. And also we need your support and guidance in future and also in other series of our interviews.
Anytime, Imran, as I told you. But if I may, Imran, when we talk about sleeve gastrectomy, I think we always should mention Professor Michel Garnier.
Sure.
I think he's the father of sleeve gastrectomy, and he did a great effort in doing the summits of the sleeve gastrectomy. Personally, I attended most of the summits except one I couldn't go, but all the summits I attended. I learned a lot from these summits, and any sleeve gastrectomy program or interview, Professor Michel Garnier should be mentioned because he's the pioneer and of sleeve gastrectomy and laparoscopic surgery.
Definite, sir. And also I will interview him, Michel Garnier, because he is the pioneer of this surgery and he will part of some obsession, because it will be a great honor for us, because without Michel Garnier, this series will be incomplete. So definite, sir.
Because Michel Garnier should be part of this series.
Definite, definite, sir. Definite. And so much thanks, sir. And it is great honor. And thanks, viewers, that so without your support, so we cannot continue such an activity. And next week, we will have also another legend. Please follow this series. If you have any question, you can ask question in your comments, and also you can ask personally. We will follow this series till December 2021. And in December 2021, we will have some obsession of sleeve gastrectomy. Sir, again, thanks. And thanks all viewers, and have a nice time.
Thank you very much.
Thank you, sir. So much thanks, sir. Thank you, sir.